Thank you for that beautiful video. And that is available on, what's the best way for people to seek that out? At pandasnetwork.org. So next I'm going to welcome Paul Hardy, as I mentioned, my mentor. Paul has had a wonderful history of challenging the conventional, I'll say for him, and trying things that were outside the box. I think probably Dr. Rossetti and probably Dr. Thompson do that, Trifletti and Dr. Thompson do that as well. But just let me say, from a person watching Paul and working in that area, it's very painful at times. You're criticized, you're scorned. It's a very lonely position as a clinician to be going up against the ivory towers of medicine. And so all of them have my great admiration, but particularly from me personally to Paul, who has his own full-time private practice now. He used to be in Hingham, Mass. Now he's in Peterborough, very near you. It's Peterborough, right? Yep. And he's a diplomat of the American Board of Medicine and American Board of Psychiatry and Neurology. Let me also say that neurology psychiatrists are not, people who have both degrees are very rare. And so when you find one, you're very lucky. He also is in the panel of professional advisors for the Autism Society of America. He was one of the first people, if you're familiar with autism and the DAN movement, that is now called, what's the organization?
It's just ARI.
ARI now, the Autism Research Institute. He was one of the first people, I think one of the first 12 clinicians who got together many years ago and started that whole treatment process, which was extremely life-saving for many, many people in the autism spectrum. So I welcome Paul.
Thank you, Peggy. I might use a little more water. All right. It's a pleasure to be here today and speak with you. And I'm not here to give you all information. I've come here today to do some problem solving. And I'm thrilled to be able to have Dr. Trifletti as a co-speaker, as he's one of the smartest people, physicians, I have ever run up against. And I'm going to talk about the challenges of evaluating and treating PANDAS, because in the past couple of years, as I've started to see more and more cases, I have been challenged more than I have ever been in my life. Now, when I went last November to the PANDAS conference in Providence, I was in awe of the passion that you parents have. Now, I've been to autism conventions, 1,000 parents in the room, for years, but nothing matched the passion that was in Providence last year. And it's understandable. I've also lost a son. Nothing compares to what some people in this room are going through. And as bad as losing a son is, you parents, some of you, are having to endure far worse suffering. So, what do I press here?
Oh, no, the down button, the down here on the other computer, the other one.
Right here. Okay, and special thanks to the Autism Research Institute in San Diego. I certainly have learned so much through this institute, and Peggy used to attend the meetings with me, and I think she learned a lot there too. Now, I must also say that I am the father of a physician, and I'm very proud of my son, but I am also very proud of this woman. And what she has accomplished for you folks over the last several years. Doesn't seem to respond. Oh, there we go. Now, the challenges are significant. New Hampshire is a state of non-believers, it seems. I'm sure you've run into this all the time. And Robin wrote this in an email to me last evening. And that's what I want to talk about today, is why is it so challenging? Why has this been such a controversial disorder? And it's not only for you as parents, but it has also been for someone like myself. I am a physician, and I've been pretty well trained along the way, both in neurology and psychiatry. But it is very difficult to speak with other colleagues and to try to get their support as we go about trying to treat this condition. And psychiatrists in particular, as well as pediatricians, are some of the most resistant to accepting this diagnosis. Now, why is this so challenging? It has been a very controversial diagnosis from the get-go. And I realize that the print on some of these slides is small. And anyone who wants a copy of my slides, just email me and I'll mail out a copy to you. Or I could even PDF it to you. It is the result of an academic turf fight between neurologists and psychiatrists. This is how it started. It was first described by a behavioral pediatrician, Dr. Sweeto, at NIMH in 1998, as you well know. Now, neurologists consider themselves the main authorities on movement disorders like tics and chorea. That's their specialty. And neurologists are also consider autoimmune and inflammatory disorders of the brain their specialty. But here is a new syndrome that's described by a pediatrician who's not even a child psychiatrist. I don't believe she's a child psychiatrist, just a behavioral pediatrician. And my colleagues resisted this diagnosis hand, tooth, and nail. Now, I have a vivid recollection of being in the Marriott Hotel at the World Trade Center in June of 2001. And it was at the International Tourette Syndrome Association research meeting. And it's usually held about every 4 years, and I've gone to them, about 4 of them in recent years. And there was just a vitriolic debate about the validity of PANDAS syndrome. And one person was from Johns Hopkins. The other neurologist, who I am somewhat ashamed to say, was from my alma mater for neurology training, the University of Rochester. And they just tore this concept apart. Then that hotel was destroyed on 9/11, as the whole downtown financial area of New York. When I went back 4 years later, and there was a different hotel that was an old hotel that had been rehabbed, there was a striking difference in the attitude. People in the audience, some of the physicians, would get up and say, well, maybe all tics have some form of an autoimmune basis. And so the tide was beginning to turn. But it has been a difficult battle, territorial battle. Now, there was also the eventual realization that it was not just streptococcus which could trigger this autoimmune disorder. There were other conditions, possibly Lyme disease and other microbes such as viruses, atypical bacteria, and thus the PANS term came into use. And in many ways, I find it often difficult to document that strep is there on a laboratory basis. It's really a historical diagnosis from my perspective. Now, I'm trained as an adult physician. I'm not primary care. When people come to me, they've had the condition usually for years or months. And I have to go back and try to figure out what went on. It's not the acute deterioration that Dr. Sweeto talks about, and which you as young parents have experienced. These have been often behaviorally disordered individuals. Many of them have autism. And as I've learned more and more about this, I can think back, and Peggy can remember them with me, of people who we tried to help with autism, who I now realize really had a form of PANDAS. There was one young man where the major problem was he was constantly going to the bathroom, and he was filled with fears. So I don't understand why this is.
I don't know why it's not going forward.
Maybe if I hit
Here, try
answer.
This one. Try this one.
Oh,
There we
okay.
go. Yeah, so use
all
the
right.
clicker.
Yeah.
Sorry.
So I believe that the controversy is so vehement because as a neuropsychiatrist with an understanding of both neurologic and psychodynamic processes, I believe this controversy has arisen out in part out of a turf battle on the part of physicians. And sometimes physicians can get very arrogant and pompous. And I'm not telling you anything you don't already know in that regard. The behavioral changes, as Peggy has described, are so varied and complex. There's the lack of consistently reliable testing, and it is ultimately a clinical diagnosis. The difficulty of obtaining spinal fluid. Now, in traditional neurology and encephalitis and conditions like that, meningitis, the first thing you do is a lumbar puncture. And you either look for inflammatory cells or white blood cells, or you look for certain antibodies or elevated proteins. And we don't commonly do this in individuals where this diagnosis is being entertained. And it's a controversy as vehement as Lyme disease, for any of you who are familiar with the controversies in Lyme disease. Whoops. Now, a controversy exists whenever there are non-specific or reliable tests. And it is clear that even in acute stages, throat cultures can be negative. They're not 100% positive or reliable in that way. The bacteria, the strep, can be in other sites of the body. Peggy and I once saw a young woman whose PANDAS was related to a strep infection on her leg. It can be in the genital area. It can be around the anus. So there are other sites where the bacterial infection can occur. And then the antibody tests are unreliable at times. Because as Peggy explained, you have to catch the rising titer of the antibody. And usually if you can get a low antibody at the early onset of the condition, and then you find it elevated 2-4 weeks later, that's pretty strong evidence that you're dealing with an acute streptococcal infection. But in some of the cases I'm going to present to you today, I'm trying to figure out whether PANDAS is a valid diagnosis years after they first became ill. And then the brain antibody and other measures that are involved in the Cunningham panel. This is an area of controversy. Not everybody accepts the Cunningham panel as valid. And as Peggy has mentioned, mycoplasma pneumoniae is often present in these individuals, and it's hard. There's really just a few tests that are helpful in diagnosing mycoplasma retrospectively, and that being the IgG and IgM antibodies. Lyme disease, influenza, H1N1 virus that was present in the population a few years ago, Epstein-Barr, herpes simplex, and then Coxsackie. So there are many different things that can contribute to the PANS, and trying to document them is extremely difficult. Consequently, the acceptance of PANS and PANDAS is as a real and valid syndrome has been greatly delayed. we're talking about 16 years to the present time since Dr. Sweeto published her paper. Only now are some neurologists and psychiatrists and pediatricians and infectious disease specialists willing to entertain the diagnosis, but they're far and few between. Even fewer know how to treat and manage the syndrome, since it crosses the neglected borderline between neurology and psychiatry. A consensus report for diagnosing and treating still does not exist after 16 years since it was first described. Now, it's my understanding that there are two groups, one on the East Coast, one on the West Coast, who are trying to put together a consensus report, but it's very hard for them to reach a consensus. And so there's nothing really that has been published in this regard. And finally, rarely is this condition ever discussed in continuing medical education for physicians. I've not seen a conference that has been sponsored by a medical school or a medical society on this topic. It's only you, the parents, who are getting the word out. Now, consequently, as doctors and parents who believe in this syndrome, we are viewed as doctors being outside the box or quacks. You as parents are being viewed as pushy, hysterical, or crazy. And I realized this morning that I really should have used a different cartoon here, or a different image. Here, this cartoon is, I'm always the one doctor out of four of five doctors that 4 or 5 out of 5 doctors disagree with. So we're in a minority. Now, the slide I should show here is the famous painting of Saint Sebastian, tied to a stake with all sorts of arrows coming out of them. Because the arrows get slung at us who are involved in this disease or syndrome, and we're looked on with askance. Now, diagnosing PANDAS is especially challenging in other comorbid developmental disabilities. And this is how I have come to it. Developmental disabilities has been my forte for the past 40 years. I started out in the back wards of a state institution for the mentally retarded in Massachusetts, really as a result of Eunice Kennedy Shriver. I had just completed my behavioral neurology fellowship, and I was a Kennedy Fellow in Medical Ethics sponsored by Mrs. Shriver and the Joseph P. Kennedy Jr. Foundation. And I decided I would try to learn something about more of the medical aspects of this, because I had really never been taught much about it in medical school or in my neurology training back in the 60s and 70s. Now, autism spectrum disorders has been one of my main interests, and after I heard of Dr. Sweeto's work and then met her at one of the Autism Research Institute think tanks, I came back. I don't think, Peggy, you were there for that first one, but I started telling Peggy about PANDAS. And we started to look around and see if we could diagnose it in anyone. And one of our first cases was extremely striking. It was a young girl who was an honors student in high school on the South Shore of Boston. And she came down with some illness that no one could figure out in Boston academic medicine. And she was diagnosed as having a psychiatric disorder. And her symptoms were constantly, and she could hardly swallow, eat, or drink. And this went on for weeks and months. And finally, we referred her to NIMH, to Dr. Sweeto's lab, which was doing plasmapheresis at the time. She had plasmapheresis, and after that, we sort of lost track of her, but she showed up in the office 2 years later, and I didn't recognize her. And she was in college, and she came back to just thank us for what we had done to try to help her. So that was one of our first experiences with this condition. I now realize that following that, there were other young people in my practice where we missed the diagnosis, the frequent urination, the excessive fears. Also in ADHD, if this gets superimposed on ADHD, it often gets harder to figure out and advocate for the diagnosis. Oppositional defiant disorder. Oppositional defiant disorder fits kids who have PANDAS, but if it's pre-existent, it's very hard to make the diagnosis or recognize it on top of that. Childhood anxiety disorders. I've had a special interest in childhood anxiety disorders for years. And so back in the early 80s, I started recognizing panic disorder in people with autism in the back wards of the state schools, both at Dever and then subsequently at Fernald in Massachusetts. And I began to then see the obsessive compulsive traits. DSM-4 was out at this time, the more I looked for various DSM-4 diagnoses in developmentally disabled people, I began to see them. Bipolar disorder was another condition that we first started to recognize in the back wards. And when you gave these individuals lithium, you could take them off so much of the haloperidol they were receiving or the Thorazine. And then depression. If any of you are familiar with the sketches by Van Gogh or Albrecht Dürer of melancholy, there would be kids sitting in the back wards in this position, severely depressed, and it was unrecognized. Now, what I'm going to do for the rest of the time is share with you some cases, and I'm pleased to be able to do this in front of Dr. Trifoletti and Dr. Thompson and Peggy, and I guess there were maybe a few other physicians or nurses in the audience, because a couple of these cases are still in the process of being figured out how to best treat them. And actually one where the real is it really a PANDAS diagnosis? I believe it is. Not many other people do. So the first, and the parents of this young man are here today. So this was a 8-year-old boy at the time on the autism spectrum. He was high functioning, had comorbid anxiety, whom I had been seeing for about 3 years. Peggy was involved at the time. He was responding well to nutritional therapies, plus buspirone, which is an atypical anti-anxiety medication, which is not habit-forming. It's relatively safe, and I find it extremely good for obsessional anxiety and what I call the worry wart syndrome. He had intermittent episodes of intestinal candidiasis, of yeast, and this would often lead to anxiety and stereotypy, and he would respond to oral nystatin for 2 to 4 weeks and sometimes for several months. And mom would call me and say, I think he's got his candida again. Can you write a prescription for nystatin? And I would. Now, one of the things that intestinal candidiasis is a very controversial entity, like Lyme, like PANDAS. Many doctors don't believe it exists. Now, a couple of years ago, I was at an autism think tank, and I tried to tell the people in the room how I actually described this case and how I felt intestinal candidiasis was a real entity, and because it responded so readily to nystatin. One very smart doctor in the room, Dr. Theo Harris, the Comorbidities, and I'm going to come back to that name in a few minutes, said, well, you know, nystatin has, and he's a professor of psychopharmacology and medicine and research at Tufts. He says, well, you know, nystatin has anti-inflammatory properties, and maybe it may be working by a different mechanism. So but suddenly he would become anxious and fearful. He had stereotypic movements in the days leading up to his 9th birthday. And he had the belief that he was becoming an old man. Now, I'm on the Amtrak train the day before Thanksgiving, going into New York City to be with my family, and I see this email from Mom. And this is what the email says. And this is just characteristic of the irrational fears, which I've come to believe is just a hallmark of PANDAS syndrome. Sorry to bother you over the holiday, but I had a concern about my son that I wanted your opinion on. My son has had the stomach bug for 3 days, fevers, vomiting, nausea, and a refusal to eat. I'm concerned about his Buspar. He did miss a dose or two the first 2 days as he couldn't even sip water. The 3rd day, our usual times for the med were off, but he did get 3 full doses. And they put him right to sleep, and he had not had anything to eat. Today, he woke up at his usual time, about 6 a.m., but he was crying. Today is his birthday. He stated he was sad. He would not be 8 years old anymore. He never cries. He proceeded to cry for 3 hours, talking about all the sad things that had happened to him and all the things that he will miss and never get to do again because he's growing old. Very dramatic, indeed. He talked about everything, like cursing John Wilkes Booth for killing his favorite president, his grandparents dying, not wanting to grow older, and crying, and you can get the drift of the agony that this young man is experiencing. Now, the fact that this was the day before Thanksgiving has meaning. And you're going to see another case that comes on at Thanksgiving, because Thanksgiving is often a time when families and children get together and the strep or the other bugs, microbes, get spread around. And so following Thanksgiving during December, January, this is one of the high peaks of PANDAS during the year. And Mom asked if it had anything to do with his missing his meds. And I really couldn't come up with the answer, and I replied, I think that we just need to watch him and keep him on the buspirone. This is sort of perversely cute. I wanted to have a funeral remembrance, he said, for 8 years of his life, before starting 9. At least he is now considering being 9, but crying again about missing being 8 and all the good times he had. So quite a dramatic email. Now, I was emailing back and forth with Mom that evening, and we decided to maintain him on buspirone. Then I saw him in early January, and he came into the office, and he was, and I knew right away what we were dealing with. So I put him on azithromycin. I suggested they start some ibuprofen, 400 milligrams 3 times a day. But I also recommended that they order a product called Brain Gain. It is a natural anti-inflammatory agent containing luteolin, berberine, and also folinic acid. And this was developed by Dr. Theorides, whose specialty is mast cell disease. Mast cells are the main inflammatory attack cells in the body. And but these particular products cross the blood-brain barrier and can get into the brain. So he began to improve. The ibuprofen was discontinued. And as I say, improved during March, January through March. The anxiety decreased, the tics almost abated. Mom tried tapering the brain gain due to its expense, but within 10 days he was much worse. And this was one of my early experiences in using a natural anti-inflammatory agent to deal with the autoimmune process. And he remains on the brain gain to this day, plus buspirone and antibiotics. Okay. Now, how am I doing here? Case 2, sudden onset after Thanksgiving of aggression, compulsions, explosiveness leading to suspension from a residential school in Massachusetts where Peggy and I have consulted and I continue to consult. Now, he had a developmental disability. He had had a right hemispheric brain injury, possibly a stroke at 18 months of age, resulting in a mild left hemiparesis, epilepsy, severe ADHD, and rigid thinking, and the learning disorder. And he became increasingly angry after Thanksgiving. Now, at that time, he was on Depakote for his seizures and Concerta 108 milligrams a day, as well as clonidine, in order to try and deal with his severe ADHD. If he missed his morning dose of Concerta, he could not function and get out of the dormitory. He returned, this was after Thanksgiving, his behavior became increasingly worse, angry, obsessed. He was having trouble moving furnitures in boxes, and he became obsessed stealing screwdrivers because he wanted to unscrew the tops of the desks at the school. Needless to say, this was not well received. In December, I started him on Seroquel, which is a major tranquilizer, at increasing doses, but he was unable to stay at school. He had to return home on a medical leave. Now, fortunately, he had been a longtime patient of Dr. Elizabeth Latimer, who had spoken at the Providence Conference. And we had shared this patient together. We had never really, we met in Providence, but we did not talk about this young man at that time. His strep tests were positive, including the Cunningham panel that was quite positive. She started him on the Zithromax and gave ultimately IVIG in January. There was a slow progressive improvement during February and March. He returned to the residential school in April. His parents would stay in a hotel on the Cape to ease him back into school. Now, this is pretty dramatic. This is in December before he left the school, before IVIG. This was a picture he drew of himself. Angry, rageful. And then this is, this is after IVIG. He has a sheet here where he can mark off how he's done at various tasks during the day. And at the end of the day, he has drawn a happy face of himself. And so he began to continue to improve. Over the summer, we were able to taper his antipsychotic medication. Mom did this at home. Seroquel was finally discontinued in August while his father was dying of cancer. This young man had previously been very angry with his father, and he suddenly began to show compassion. His father passed away in early September. This young man came back to the school, much less medication, and so far, so good. So, all right. Now, here is a case of a young man who's had severe behavioral problems for years. Both families, he had two parents who were divorced. Both families bought homes on the Cape because he could not go to the residential portion of the school. He would go part-time to the day school because he was so anxious and fearful. And then I saw him for the first time in October 2 years ago. He had been previously diagnosed with autism spectrum disorder, bipolar disorder by Dr. Thomas Post at NIMH, who was a leading authority on the use of anticonvulsants for as mood stabilizers. And Dr. Post had diagnosed him with bipolar disorder. And he was started on Depakote to reduce the mood swings. Now, further history revealed episodes of severe anxiety and panic. I made a diagnosis of panic disorder the day I saw him. He had sleep problems, startle response, he disliked crowds. On initial exam, he had high blood pressure. He was 18 years old at the time. No, 19. And he had a tachycardia, fast heart rate. He was very fidgety, restless, poor eye contact. I suggested the panic disorder, but he had anticipatory anxiety, but I felt that he was very hyper-aroused. It was that fight-flight nervous system that Peggy spoke about. And so I prescribed some clonidine, and he started to level out and improve. In January, he was able to enter the dormitory, and during the spring, he slept in the dormitory most of the time. He was home on weekends, still had episodes of anxiety, and it was a rocky course. In early October 2013, just a year ago, I happened to be in France on vacation, but I was getting 20 emails a day from the biologic parents. He was in a downturn. And one of the parents revealed that they hadn't been able to respond as quickly as they would have liked because they were out of commission with another episode of severe strep. So from Normandy, I said, bingo. This is what we're dealing with. In a man now in his late teens who probably had his first episode of strep back as a child. His strep test, the ASO was elevated, and also his DNase B antibody. And so he was probably also a carrier, but the throat culture was negative, and oftentimes that's the case. His Cunningham panel was quite positive. With this CAM kinase, this marker right here, which is according to Dr. Cunningham's lab, and in speaking with them, is strongly supportive of neuroinflammation. And at that time, last fall, they were using this bar graph to indicate the likelihood of this being a neuroinflammatory disorder. Now, I started him on antibiotics in October, started to get better. Easter break, he went home and the nurses forgot to put the antibiotic in his medicine bag. They called me right away. I thought, well, a few days off antibiotics should not be a problem. However, when he got back to school, they forgot to restart it. And there was a med mix-up. And within 7 days, his behavior started to deteriorate with increased anxiety, explosiveness. And I've continued with the antibiotic therapy since then. This summer, he was actually able to hold down an internship working at one of the hotels in the laundry room on the Cape. He was quite proud of himself, as were the parents. He has remained, though, on high doses of Seroquel, 300 a day. I did some genetic testing and found that he's a rapid metabolizer of Seroquel, so he chews it up, and I don't have to feel quite as guilty about having him on that much medication a day. He's on buspirone 90 a day. Now, family would like him on less psychotropic medicine. So would I. He's at increased risk for tardive dyskinesia and some other side effects. But he's not considered severe enough, according to some clinics in New England, to receive IVIG. So one of the questions I have for Dr. Trifoletti is whether I should proceed with IVIG, because in this situation, the family can afford it and not have to go through Blue Cross Blue Shield. So we'll get to that maybe in the question and answer period. Now, this is one of the most difficult and heartrending cases. It's a set of identical twins, yeah, who developed, they had an infection in they finished the 8th grade with honors 2 years ago. They then had some peculiar illness in the early summer, and by late summer developed anorexia, both of them. It became worse and worse, and they had to be hospitalized, both of them together. They also developed really psychoses. They became combative. They had to be restrained in the hospital. Got progressively worse. They had to have IVs. They hated IVs and fluids coming into their body. They were afraid of them, so they were kept in restraints. They were started on high-dose antipsychotic medication during the hospitalization. Now, when I started to think about this case, I was struck by here we have identical twins, supposedly a normal genotype, nuclear, but they had a different phenotype, a clinical picture, how they presented. Now, I started talking to Dr. Trifoletti over lunch about this, and he started to point out it may be the mitochondria, which can have pleomorphism. So, anyways, this is a New Hampshire family. Initial hospitalization lasted 9 months at $1,700 a day. In the other twin, it was 6 months at $1,700 a day. The Commonwealth of Massachusetts tried to remove the children from the care of the family. Where have we heard that before? One of them had severe POTS, which is postural orthostatic tachycardia syndrome, and she would faint. At one point, she fainted, fell on her jaw, and knocked out several teeth, and is going to have implants. The other one developed severe headaches. The amount of psychotropic medicine that they were on at discharge created cognitive blunting, and they couldn't really perform back at school. They had lab tests that were equivocal, positive or negative. The one thing that was consistently positive was Mycoplasma pneumoniae. And I would welcome Dr. Trifoletti's thoughts and Dr. Thompson's thoughts on that. All the other things like Epstein-Barr, Lyme, other tick-carried spirochetes were negative. One of them had a low complement level. The other, their complement levels were normal. So this was their, these are their Cunningham panels, particularly this one, who is less clinically severe, has a more positive Cunningham panel. But their CAM kinases are elevated, suggesting that there's a neuroinflammatory disorder. Now, since I've been caring for them, they've had to have 2 more psychiatric hospitalizations each. One was admitted to Mass General because she had psychogenic seizures. I was ecstatic because I thought Dr. Williams could see her. It never happened. She ended up being in a pediatric cage to control her behavior. She was subsequently admitted, transferred to a psychiatric hospital in Massachusetts. So they've had these multiple hospitalizations. One has POTS, the other has severe headaches. And during an inpatient workup at Dartmouth, the one with the headaches had a lumbar puncture, and I've asked them to save the fluid for subsequent testing. Now, one has had continued severe depression and is having more eating problems. They have both lost friends and are isolated at school. One is unable, the more severely affected one, to attend school this fall. The other, it's a rocky course. I estimate the cost of the more severely affected one to be somewhere between $300,000 and $500,000, and the other $200,000 to $250,000. Now, if there was a treatment that might help them, you would think Anthem Blue Cross Blue Shield would want to try to explore that therapy. No, rejected. And the filing an appeal is an extremely arduous process. This family doesn't have the resources that the other family has. Here they've got twins. It's going to be somewhere between perhaps $12,000 and $15,000 for each daughter. And these are the medications they're on. And I suspect that a lot of these medications could be reduced if they responded to IVIG. Throughout their illnesses, the physicians, mostly psychiatrists, have thought I was a quack and a crackpot trying to entertain this diagnosis. Both twins have been given a variety of psychiatric diagnoses, DSM-4, DSM now 5, but always with the caveat that it's an atypical psychiatric diagnosis. Both parents are thought by the girls' psychiatrists to have various unkindly psychiatric diagnoses. Mom is a nurse, and the term Munchausen syndrome by proxy has been thrown around. When the girls were in their first psychiatric hospitalization, they were pumped to try to get a history of father having molested them, which was traumatic for them. And so Anthem Blue Cross is rejected. There are no, quote, evidence-based studies to support the use of IVIG. And the appealing of this decision is arduous, time-consuming, and one of them potentially is going to have to be hospitalized soon. So a concluding slide. What needs to happen? We need more research. We need more published articles, especially consensus report or reports. We need to have physician CMEs, as well as for nurses, especially school nurses, and other health professionals. Now, I understand there are some school nurses here. You are often on the front line in dealing with these children, and I would hope that school nurses could begin to become educated to pick this up and get them to the pediatrician, or to certainly inform the families about what the possibilities might be. We need more funding, and we need more advocacy from you folks. Thank you very much.
Thank you very much, Paul. It gives us a lot to think about. We're going to have a bathroom break at 3 o'clock, so hang on if you can. I'd like to introduce Josh Leary and his mother, Andrea. I think they've come in. And they're going to talk about